Lung tumours are the commonest cause of death from cancer in New Zealand in both men and now women. When we think about lung cancer, we've got to think about primary cancer and secondary cancer, in other words, metastatic tumours. Of the tumours that arise in the lung, the vast majority of them are malignant and arise from the epithelium of the bronchi, thus they're called bronchogenic carcinomas. There are a few other tumours that occur, and we'll mention them at the end of this talk. Metastatic tumours are found in 30 to 50% of all cancer patients. Their commonest sites of origin are breast and colon, but interestingly also the lung, because lung cancer metastasizes around the lung. We can tell the difference between primary and metastatic tumours by looking at their number and distribution. Metastatic tumours are often described as multiple cannonballs throughout the lung. Thinking about bronchogenic carcinoma, there are four main types: squamous cell carcinoma, adenocarcinoma, large cell undifferentiated carcinoma, and small cell carcinoma. Some of the risk factors for lung cancer are well publicised. Tobacco smoking, for example, gives someone a 10 to 20 times risk of getting lung cancer. Now we also realise that environmental particulates play a role in causing cancer. Some people are exposed to asbestos during their work, and they have a very much increased risk of lung cancer, particularly if they smoke. Radon is a gas that can accumulate in houses built in granite areas or of granite. For example, in Aberdeen, the Granite City, radon can accumulate in houses and the radiation dose can give lung cancer. Finally, areas where there have been scarring can act as a nidus for lung cancer. Adenocarcinoma is typically a peripheral mass. It can be associated with scarring, which again usually happens peripherally. About 75% of adenocarcinomas arise in smokers. It is the most common tumour of non-smokers. Despite this, more smokers than non-smokers still get adenocarcinoma. It has mutations that make it amenable to therapy, drugs that can be directed against the mutations driving the cancer. Adenocarcinoma down the microscope makes glands. All adenocarcinomas do. The second type of tumour is squamous cell carcinoma. Now, if you remember your histology, there is no squamous cell mucosa in the normal lung. That's because smoking causes metaplasia, changing the normal glandular epithelium into metaplastic squamous epithelium. It's this metaplastic squamous epithelium that then becomes malignant. Squamous cell carcinoma is closely correlated with smoking history. Squamous cell carcinoma arises in the larger central bronchi and forms cream grey masses that can cavitate in the middle due to central necrosis. In the remainder of the lungs, you'll be able to see smoking-related changes. Down the microscope, squamous cell carcinoma forms nests of squamous cells. They look malignant, pleomorphic, hyperchromatic, with lots and lots of mitoses, but we can still see their squamous cells because they produce keratin and have intercellular junctions with spikes. The third type of lung cancer is large cell undifferentiated cancer. This likely represents very poorly differentiated squamous and adenocarcinoma, so bad that we can't recognize it as either squamous or adenocarcinoma anymore. The fourth kind of cancer is small cell carcinoma. It has a really strong relationship to cigarette smoking, with only about 1% occurring in non-smokers. Small cell carcinoma is the most aggressive form of lung cancer. Again, it's centrally located around the hilum, but it's widespread through the body at diagnosis. It's already metastasized. This is why small cell carcinoma is never treated by excision. Chemotherapy is the mode of treatment, the only mode that will treat small cell carcinoma. Its other interesting point is that it's often associated with ectopic hormone production. Here's a small cell carcinoma. Notice its central location. It's a large tumour, white and fleshy. The lung around it is black. We call this anthracotic change, smoking changes in the uninvolved lung. Down the microscope, we can see that small cell carcinoma is made up of small blue cells. They have little cytoplasm, so all the nuclei crowd closely together. Sampling the tumour often leads to crushing of these delicate nuclei, giving what we call crush artifact. All of these cells contain neurosecretory granules. Let's think now about the more modern ways that lung cancer is treated and how pathology contributes to this. Pathology testing can be used to detect treatable mutations in lung cancer. If you look to the right here, you will see the pathway that drives some kinds of lung cancer, about 20% of lung cancers. Sometimes a mutation in EGFR, the epidermal growth factor receptor, will keep it switched on and drive the pathway. In other times, a mutation in ALK will drive the pathway. Both these mutations are druggable. Specific antibodies can be made that block the actions of this pathway, and thus patients can live an extended life with lung cancer if they have these mutations. Let's move away from bronchogenic carcinoma now and think about neuroendocrine lung tumours. If you remember your embryology, the lung is part of the foregut and thus has gut-type neuroendocrine cells in it. They contain neurosecretory granules, and we can identify them by using immunohistochemical staining against the neurosecretory granules. Small tumours can arise from these neuroendocrine cells. They used to be called bronchial carcinoids when they were benign, but now we call them neuroendocrine tumours grade 1. They occur in younger patients. There's no relationship to cigarette smoking, and they secrete hormonally active peptides, which is why they can give carcinoid syndrome if they secrete 5-HT. Because these tumours are benign, they grow within the bronchi and occlude the bronchi, giving rise to a polypoid mass. They're usually quite small, about this big, 3 to 4 centimetres. They can obstruct the bronchi, causing lipoid pneumonia distal to the obstruction. Small cell lung cancer is a neuroendocrine tumour grade 3. Now, it may not arise from neuroendocrine cells. It might arise from bronchial epithelial cells that have gone really, really bad. As I mentioned before, it's not surgically treated. We diagnose it by sputum cytology and bronchial biopsy. It's a tumour with a median survival from diagnosis of only 2 to 4 months. There still is no specific treatment for small cell lung cancer, unlike adenocarcinoma. On my right here, you can see paraneoplastic syndromes associated with lung cancer. Most paraneoplastic syndromes are associated with small cell carcinoma. The syndrome of inappropriate ADH, myasthenia gravis, and cerebellar degeneration. Squamous cell carcinoma also has some paraneoplastic syndromes that can be associated with it, particularly hypercalcemia because of the production of parathyroid hormone. We have a poor understanding of how adenocarcinoma causes hypertrophic pulmonary osteoarthropathy, in other words, the little nodes you see on the fingers of lung cancer patients. This is a Pancoast tumour. So what is Pancoast syndrome? When the lung cancer affects the top part of the lung, it can entrap many important structures, such as the brachiocephalic vein, the subclavian artery, the phrenic nerve, and the recurrent laryngeal nerve, even the vagus nerve. Think of all the symptoms that could cause. In fact, it's anhidrosis, meiosis, and ptosis. Can you link those to the different nerves it involves? Mesothelioma is the last tumour we're going to think about today. It's a tumour of the covering of the lung, the pleura. It involves the pleura diffusely. It encases the lung. It invades then the lung parenchyma and also the chest wall. Asbestos is a well-known substance that increases the risk of mesothelioma. However, smoking and asbestos markedly increase the risk of bronchogenic carcinoma. In fact, the commonest tumour in people who've been exposed to asbestos isn't mesothelioma, it's bronchogenic carcinoma. Smoking isn't related to mesothelioma. Thanks for coming with me on this journey today through lung cancers. Get to know your lung tumours and how to treat them, and you can be a pathology superhero!